Good evening, everybody, and welcome to this evening's meeting of Health Scrutiny. Apologies for the late start. I would also like to welcome everyone in the audience who is attending. It's very nice to see so many people. Thank you so much. We're really delighted to share our proceedings with you. And we also apologise for having our backs to you, and we're going to do it differently next time. So apologies for this time. It doesn't feel quite right. So I do have to start with a little bit of housekeeping, and it's really just the announcement of our fire safety notice. So if the fire alarm, which is a continuous siren, if that sounds, please could I ask that you leave the building in a calm manner by the nearest exit by proceeding left out of the room and down the main stairwell and out of the main civic entrance, which is opposite. Everyone should assemble at the front of the town hall and must not re-enter the building until instructed to do so. If you have a disability which could affect your means of escape, could you please inform a member of staff so that arrangements can be made for your safe evacuation? Thank you. As usual, for a committee of the council, we are webcasting live. Just before we press go, could I just read you also the following notice, and you can let me know if you're happy to proceed. So please be aware that this meeting will be recorded for live and for subsequent broadcast on the council's YouTube channel. The whole of the meeting will be recorded except where there are confidential or exempt items. This activity promotes democratic engagement in accordance with Section 100A, Section 9 of the Local Government Act 1972. The cameras will focus on the proceedings of the meeting and avoid areas specifically designated for members of the public. If you object to being filmed, please remain seated in the public seating area. So if anybody doesn't want to come onto screen, then please just remain where you are and you will not be captured. Thank you. Okay. So also, members and officers must use microphones provided to enable the audio to be picked up by the system. And members are reminded kindly to turn off their microphones when they are not formally addressing the committee. So could I just check that everybody is happy with that? Yeah, understood. Fantastic. Thank you so much. So we'll formally start our recording and open up proceedings and welcome everybody to this month's meeting of Health Scrutiny Committee, and just start with our agenda, which is attendances. And I believe we have had an apology.
Yes, Chair, we received an apology from Councillor Thomas.
Thank you very much for that. So Councillor Thomas's apologies are noted. And then we move to item 2, which is declarations of interest. And please could members, any members who wish to give notice of an interest in any of the items on the agenda, please declare those. Councillor Dr. Carr.
I am employed by the NHS and Salford Royal Hospital, and therefore have interest in agenda items by virtue of that employment.
Councillor Taylor.
I am also an NHS worker, but outside of Trafford.
Anybody else? No one else? Okay, thank you so much for that. We don't have any urgent business, which is item 3. So we'll move on now to questions from the public, which is item 4. And we are allowed a maximum of 15 minutes to hear any questions from the public. I'm delighted to say we have had a question. We're very happy to take that question from Mrs. Judy Collins. Mrs. Collins, you're happy to address the committee? Yes, please. If you're happy with that, that's fantastic. Thank you so much. So Mrs. Collins will read her own question, which is always very nice to hear direct. Thank you.
My question's about transfer of people from their homes to either the hospital or into the community. A couple of things have come up. One's concerning PAT boards, which is the North West Ambulance use them to transport people, say, from a nursing home to a hospital as an emergency. We had a case where the ambulance wasn't carrying theirs, the nursing home didn't have one either. So I'm just wondering if there could be something in place. Diane Eaton knows the particular circumstances. some sort of indication of how we can get around the problem. Should the nursing home have them? Should the ambulance carry them on the vehicle? And in a similar case, somebody from Trafford came to the Broadheath Partnership to say that we were now offering to take people from their homes so they weren't socially isolated. But again, there's a problem. They're not allowed to go into the premises to help them out. Neither are the community transport or the services that offer charity transport. So again, if we are providing a service for people to come out of their homes to go to luncheon clubs and things, we can't actually get them out of their houses. It looks as if we need to look at what the problem is.
Thank you very much, Mrs. Collins. That's a really good question. So we do have an answer for you. It was provided by the North West Ambulance Service and also Trafford Council. But if you feel it doesn't cover the question that you've raised specifically, or if you have concerns about actual cases, very happy to follow those up for you. So I'll read out the response that we've got, and then you can please contact me and take it further. So the answer from the North West Ambulance Service states, all clinical staff receive mandatory training in moving and handling patients. All vehicles carry varying equipment, including handling belts for assisting patients to move, transfer boards, which are smaller than PATs, slide sheets, now I hope I'm pronouncing this right, manger elk lifting devices, and patient transport chairs, which are carrying chairs. They also would always carry wheelchairs, stretchers, and in some vehicles, turntables and small version PAT slides. So if you've had an experience or you know of experiences for our residents where they've not had those, I think we need to look at that and take that further. Okay, so for Trafford Council, their response is the following. So Council says, if someone is struggling to get out and about without support, there are various options available which depend on the level of need of the individual. These range from requesting a blue badge to enable parking closer to the destination, vouchers for a taxi service, ring and ride, support to claim mobility benefits, use of wheelchairs, electric scooters, or adaptations to motor vehicles through the Motability Scheme. The use of a PAT board would indicate a specialist requirement and shouldn't be used without prior training. Therefore, it's recommended that full occupational therapy assessment is arranged to support any specific requirements. And this can be arranged via the One Stop Resource Centre and then there's a phone number for people who are interested. It's 0845 299 0798. This would then inform the requirements of a package of support at home or in a care home. So that's the response I've had, Ms. Collins. Do you feel that covers it, or do you feel you would like more individual
I don't
response?
think so. The problem is that nobody is authorised to go into somebody's house to help them out. I gather that's the problem, according to one of your officers who came to the Broadheath Partnership. Okay,
so I think what I'll have to do is take that back and we'll get a more detailed response for you if that's okay. Yes, Councillor Haddad.
I was interested to hear Mrs. Collins. Thank you for your question. It's a very important one, especially the high risk of loneliness in people with mobility problems. I was interested to hear that the voluntary organisations can't go into the homes and help with the lifting and handling, and I would have a question really about that, if that's what they want to offer, because as Chair has said, all NHS staff, it's mandatory training. So if they're offering that service, I would have thought that they would have considered this in the round. And St John Does Ambulance, in fact, do offer levels of training for first aid, manual handling, and those sorts of things for not just people who are professional healthcare workers, but people in voluntary sectors. So I would think that they should look at that and, consider what it is that they want to be offering from the voluntary organisation.
Because, if Ring and Ride won't offer it, they're fully equipped for wheelchairs and everything on the vehicles, but that's my understanding that they won't. And of course, the voluntary transport services vary a lot. Some are fairly large charities like Call, Some are just a local one, really, with, no training, just sort of giving people lifts. But I understand this is a new service for Trafford to try and get people out of their homes and into the community. So I think it's particularly worrying that there's something stopping them.
I would really suggest and encourage you to try and, speak to St John's Ambulance and see, how they work with voluntary sectors, and if they can give you some
I'll
good
go
advice.
back. I'll go back to Anna at the Broadheath Partnership and get her to do it as it's the council. Okay. Thank you.
Okay, we have a number of councillors who would like to speak to you, Mrs. Collins. So take them in order of requests. So it's Councillor Taylor next, please.
Hello, Mrs. Collins. Thank you so much. I think it's a really valid point that you raise. And I'm just wondering, how do those people who want to have transport services and to go out of their homes and join in social activities, are they self-selecting or are they identified by the council? I'm just wondering, because I'm thinking, as part of the being able to access the services, should there be some kind of mobility screening or moving and handling assessment that that occurs sort of prior to that, and then people who do require that extra support are identified and appropriate transport can be arranged for them, rather than just say, well, we'll send a ring and ride, for example, and it turns out that it's not the right level of transport, and transfer help isn't available, really. I don't know, it's something we need to look at, really, isn't it? It says it's recommended that an occupational therapy, but it would seem that anybody who, there's some way of screening people to identify if assistance with transfers and mobility is required before they start a transport service, really. So that's something we could look into, isn't it?
Okay, thank you, Councillor Taylor. I think possibly it's probably best if we carry on the discussion outside of the meeting. Obviously, we'll definitely be following this up, but any just very, very brief comments, please, from councillors who would like to speak. Councillor Canola, did you want to say something really briefly?
Yes. Is it actually not just the transfer? Is it also about actually entering the house?
Yeah. Yeah.
Okay. And Councillor Acton, just very briefly, please.
It just seems to me, Chair, that what we need is to understand exactly what the issue is and what the volunteers are allowed to do, what they're not allowed to do, what the professionals are doing, and just bring back some kind of report, or somebody could answer some of the questions that have been raised here. We're not going to, we're not going to do it now, are we? We just need further information to see what we can and what we can't do.
Yeah, absolutely. So as I said, that I will communicate with Mrs. Collins and we will look at the individual cases, but we obviously need a more general approach to what's being taken on a kind of regular scale within the council. And we will bring a report back for Health Scrutiny Committee members so that we can all be updated and know exactly what's going on, and if necessary, request some more detail on that if we want it. So thank you so much. Thank you. Moving on to our next item, we have minutes of the meetings. We actually have two sets of meetings. So excuse me, I'll just speak to the officer. Yeah. Yeah, we have our minutes to look at. Yes, so it's just we had questions, which is item 4, and then item 5 is the minutes. I just wondered if you could just approve the minutes of the meetings. We have two sets of minutes to approve. There's the Health Scrutiny Committee minutes from the 27th of June 2019, and then we also have the minutes from our meeting. I'm trying to think when that was. That was in 24th of July, which was at the Hub in Altrincham. Are people happy that the minutes are a true record? I have a proposal. Okay, fantastic. Thank you. Minutes are accurate. Thank you so much. Okay, so now moving on to our agenda proper. looking at our first issue, which is the psychological therapies for mental health conditions. And we wanted to put a spotlight on provision in Trafford. And just really, really briefly for members of the committee, just to refresh the situation and for members of our audience. The reason we selected 2 mental health issues to look at tonight is because mental health within the borough is one of the council's main 5 priorities for health. And we wanted really for the work of Health Scrutiny Committee to dovetail with the priorities of the council. So Vice Chair and myself, we met to discuss which topics we should look at. The mental health was obviously clearly very important. And we felt the 2 things that we needed to scrutinise, because it hadn't been before committee for some time, if at all, was access to talking therapies and also suicide, and looking at the audit that council has recently undertaken and the new plans that have been set up. So that's a little bit of context for why we're actually looking at those topics this evening, and I hope that committee members are happy that we have taken that approach. So I just wanted to say that in covering this topic, we felt it was really, really important not just to ask council officers, because clearly the council is absolutely crucial to the delivery of our services, but we also wanted to get information and testimony from beyond the council. So with a lot of effort from our officer, which I'm most grateful, we have managed to secure somebody from the Samaritans. Mr. Robert Jackson is here. He's the director of Manchester and Salford Samaritans. Most grateful. Stay in your place for a minute. Thank you so much. I just wanted to extend a huge thank you, giving it your time, coming this evening. Committee really, really appreciates outside views, and particularly voluntary organisations. It's absolutely fantastic to have information from there. We did also ask just for information. We asked for somebody from Advocacy Focus. Unfortunately, they were not able to attend. And we also approached Mind, and again, no one was able to attend. And I think it's quite, it's a shame that we can't really meet at times when obviously people who are working already voluntarily can give up their time more easily. I mean, maybe evening meetings make it hard, but I appreciate that, people can't come in the evening, and that's a shame, but we appreciate the fact that they responded to let us know. So without further ado, I will ask our first contributor to the discussion, and I think that will be, is it our Chief Executive of the CCG, I think, is it, to address committee. We all have a report. I presume that everyone has read it. No, because he's come for, yes. So it's Mr. Pritchard, please, who is the Account Officer for NHS Trafford and the CCG. If you'd like to, Mr. Pritchard, are you addressing committee or no? Okay, so is it Mr. Taylor? Have I got your title right, Mr. Taylor? Oh, you got Taylor. Okay, fantastic. Well, thank you so much. Absolutely, we're delighted that you've done that. Thank you. Okay, no problem.
Would you like us at the end?
Yes, please. That's wonderful. I really do apologise for the configuration. It is not ideal. We're going to change it next time. Thank you. So just while you're settling, I'll just explain to members of the audience that when we looked at our joint strategic needs assessment, which was on the websites from December 2017, it looked like Trafford was really not performing as well as it possibly could do in terms of accessing the service. And we all know that nationally there is a shortage of provision, that there's more people needing the service that can access the service. And so really we wanted to hear what Trafford have been doing about it, and to learn more about how the service is provided. And so really appreciate your input this evening. Thank you.
That's a great pleasure, and thank you for your interest. Just before starting, if I introduce myself, my name's Rick Taylor. I lead mental health and learning disability commissioning for the CCG. And colleagues are Dr. Dale Huey at the end of the table. Dale is the clinical lead and also the strategic lead for our main NHS provider, Greater Manchester Mental Health. And Kate Tomlinson is our clinical lead in Trafford. So both people are here and can answer any questions. We also, though, commission with Self-Help Services, which is a voluntary sector organisation who couldn't join us this evening, but they're our second partner in the delivery of IAP services. So again, thank you for your interest. Absolutely acknowledge that the performance that you quote, which was the 2017-18 performance, was poor. But I hope there's reassurance to be gained from the fact that since then our performance has improved and we've met every target since then, both in terms of access but also in terms of quality and waiting time. So the performance now is good. And at this moment, as we sit here, approximately 20% of adults who are understood to be needing a psychological intervention are receiving that intervention. So whilst your concern was that it was 1 in 10, it is now 20%. I'd also just say that in terms of the CCGs, but also the council's longer term planning, IAPT is really fundamentally important. And it's part of our strategy that is really attempting to shift the balance away from having to always deal with crises that emanate from mental health difficulties to a system that is much better able to prevent, identify early and prevent those crises developing. So IAPT absolutely underpins that. And recently, just in April, we've launched a primary care mental health and wellbeing service, which is an integrated service where we've got third sector colleagues working with our NHS providers. And as part of that, we've actually embedded some additional IAPT capacity. Dale and Kate will answer any questions you have and will briefly describe the service. But I would just briefly say from a commissioning angle, we've certainly got challenges ahead of us. IAPT, as a set of targets, was born out of the 5-year forward view for mental health, and that began in 2016. It is absolutely clear that the targets will continue to ramp up. They ramp up this year, they ramp up next year, and it is highly likely that those targets will increase again over the span of the long-term plan. At the moment, I think we are envisaging that by 2023-4, we would need to be delivering for around 31% of eligible population. So it is an incrementally growing target. And being absolutely blunt, that presents challenges. It presents challenges in terms of resource, in terms of money. We are currently working very hard to make sure that we will deliver this year's target. This year's target is a 21% access target. We actually achieved that last year, just to say. Last year's target was 19. We overachieved. So we want to maintain that. We certainly have challenges around workforce. Because it's the 5-year forward view, it's probably obvious for me to say that every single CCG and local authority area in Greater Manchester is also trying to deliver increasingly demanding targets. So the notion of us all fishing from a pretty small pool of workforce is an apposite one. I would say that there's some confidence in Trafford in that staff seem very attracted to working in Trafford. And when we recruit to our services, we tend to do so pretty well. So there's some confidence around the workforce, but I would not want to underestimate the challenge. We are looking at a variety of options in terms of accommodation, because of course, the more people we see, the more spaces we need to see them in. And there's a whole process of work around that. We will need to innovate. We're already offering online psychological therapy services. So we're using technology already, but we're going to have to keep thinking about that and keep working at that. But we're also going to have to think very carefully about how we integrate with physical health services, how we integrate with leisure services, how we integrate further with the voluntary sectors. There's a whole range of innovation that we still need to keep working hard at. But I think we're on that and we're doing well. The psychological needs of people with long-term physical health problems is a really significant issue. Not only because of the distress it causes people, and that is absolutely the primary issue that we would want to address, but the psychological needs of people and the distress they feel actually increases the costs of physical health care, some estimate by up to 45%. So we are absolutely working very, very hard at making sure that we are identifying people who have long-term conditions who would benefit from a psychological intervention. And that really is how I think those incrementally ramping targets will be met over the coming years. And I think the final thing to say is that we need to keep working very hard to make sure that access is not only increased, but it's increased equitably. So it's not just about numbers. I also think it's about vulnerability. It's about the demographics of our communities and making sure that all of our communities can access equally. At the moment, we have got a lower access rate in the north of the borough And I think we need to work hard at understanding why that is and making sure that our relationships with a whole range of individuals, third sector providers and communities themselves enables that to change positively. So that's just a very brief introduction. If I may, and the committee's okay, if I could just introduce Dr. Huey and Kate, and they can talk more about the service itself.
Thank you very much. Yes, please do.
Hello, hi, I'm Dale Huey. Before talking about the service in Trafford is very close to my heart. I used to do Kate's job, and it was my first post in clinical leadership within this organisation. Rick commented that the performance in 2017 and 18 was very poor. The reference point that brought us, or enabled you to ask the sensible question why we only got 10% access, was in December 2017, was 1 month. 2017, 18, the year before and the year before that, and continually since then, Trafford Psychological Therapies, which is the name of the service in the borough, has been in the top 5 performing IAP services in the north of England. Prior to that, it was, and when I say performing, I mean on access time and on effectiveness. In the paper that Rick summarised for you, and in the presentation that was appended, you'll see recovery rates for last year of 61%. That is profoundly good. I can't tell you how difficult a criteria that is. That basically means it's 61% of the people who enter therapy scoring in the clinical range on depression or anxiety measures leave therapy scoring in the clinical range on neither. That is an extremely tight criterion to apply. If we look at things like reliable improvement, have people's level of distress decreased? If we look at patient experience, what do people say about the care they receive? I couldn't be more proud of the service that we provide in Trafford. It's an absolute flagship on those criterion. Where we have struggled, and I think it is right, and with the support of the CCG and some innovation around trying to find other things that will enable the conditions to deliver an excellent service, is on access rate. Now, access rate or prevalence met is a KPI, key performance indicator, that NHS England used to hold the CCGs to account around a very gross measure of equity. And obviously, we want to be delivering a quality service to as many people as possible. However, for every 1% increase in prevalence, you're talking about hundreds of people accessing therapy that year. So for every round about 90 people who access, we need a fully qualified, full-time member of staff sitting in a building that's fit for purpose, that's accessible for people who use public transport, who've got transport of their own. We know that some of the things that aren't in the headline figures, such as attrition rates, etc., we are dealing with a population who, by definition, are very avoidant and withdrawn, experiencing the worst time of their life by and large. And if you look at comparators between physical health problems, some of the other long-term conditions, and mental health problems, the impact on quality of life and the impact on functional limitation, if you look at World Health Organization studies, is more profound with depression and anxiety disorders. So it's very difficult to get people into therapy, and once we get people into therapy, we need to keep them there. To do that, we need the appropriate accommodation where it's accessible, where it's as easy as possible for people to attend. And that's been a real struggle, and we envisage that continuing to be a struggle as we increase towards 31% of the population entering. What I would say on a slightly brighter note to that is that the NHS England figures for prevalence have just been released, and that will change after 2021. And probably the simplest way to put it, of the 10 Manchester boroughs, using a more recent estimate of what percentage of the population have a common mental health disorder, as in an anxiety disorder and depression, everywhere has massively increased in terms of what that 25% would equate to, except Trafford and except Stockport as well, actually. But Trafford, of all of the 10 boroughs, the revised figure for what 25% looks like on the more recent data it's not that recent, but it's 2014. The original data was 2001. And what I would like to believe is that that's not just a random variation, but that's to do with the fact that we are making some inroads into the needs of the population. There's a massive amount of work to be done. But I think that's something that we can observe and take seriously. If not feel proud of, at least think actually we're not going the opposite direction. And it fits with some of the other indices for Trafford as well in comparison to the rest of Greater Manchester. And I think the other thing to say that there's a lot of, I'll stop talking and leave it for questioning, but the other thing to say is that there's a lot of other initiatives that have been implemented by Kate and the rest of the service around trying to not just look at access rate and a gross measure of equity, but looking at proportional access to make sure we are representative of our population, going out and trying to reach people where they are in order to facilitate that, trying to enable self-referral and electronic referral to make it as easy as possible for people to access and overcome some of the barriers, age, gender and ethnicity-wise to access. And there's a myriad of other initiatives which are occurring, which I'm sure we'd be happy to talk about if you would like to know anything about that.
Thank you very much. That's really interesting and helpful. And would anyone else like to contribute? Are you speaking or just taking questions? Fantastic. So thank you both so much, for all three of you, in fact, for coming. But thank you so much for that really helpful extra information. It's really great not to have had just the reports read back to us. That's really wonderful extra information. Really appreciate that. So we have questions already. Councillor Dr. Carr.
Thank you for coming and for that report. That's very, very enlightening and also very helpful. I guess my concern would be on hearing this, that to some extent a lot of the access and uptake is in the south of the borough, which to some extent, unfortunately, with mental health issues is low-hanging fruit, really, in that we don't see the same levels of social deprivation, unemployment, chronic ill health, and all these things that we know worsen mental health. So I do think we need to understand a bit more about how we plan to increase access and uptake in the north of the borough, and in order to really meet the needs of the population, which is what we're aiming to do, and whether we plan any extra support and how to tailor those services best.
Forget my button. Yes, no, thank you. I think you're absolutely right. When we say that the access rates are lower in the north, they are, but there is still a good access rate, but it is certainly lower. I think there's a couple of things that we are doing. When we launched our primary care mental health and wellbeing service, we launched it in the north, and we concentrated on the north for the first quarter because of those very issues. And so we have been developing relationship with general practice. We've been developing relationships with local voluntary services and local communities to try and get as much information out there and encouraging as many referrals as possible. We are actively looking at the registers that are held by GPs in terms of people with long-term health conditions. And that applies just as much to the north as anywhere else. And that will be an opportunity for us to absolutely target people who are deemed not to be managing their long-term conditions particularly well. So we'll be offering them a service. I think there's a whole range of things that my colleagues can talk about in terms of how they're actually going out and seeking people. But I think fundamentally, the issue for us is that we have to make sure, and I don't think this just applies to IAPT, I think this is just as relevant to dementia services and other services. I think we have to shift from perhaps always believing that we do all the delivery to a concept where we are absolutely capacity building within communities, where we are sharing expertise, sharing knowledge, learning from the communities as to what we're doing right and wrong. And I think that can only be done by the means of engagement that we're trying desperately to do through voluntary sector, local people, churches, temples, etc., etc. I think some of those are the mechanisms, but there's more that I'm sure you could talk about.
I would just like to say that one of the initiatives that's been done in Trafford in 2016, and we're currently repeating in other boroughs and we'll come back to Trafford, is to look at the referral rates in comparison to the list sizes for particular GP practices. So if you like, how many people are registered at a particular GP practice, how many people proportionally do we get referred? What our colleagues in the CCG enabled us to do was not just look at referral rates, but also to look at prescribing rates for psychopharmacological medication. So there's an ADQ calculation in terms of proportionally for a particular practice. Do they refer a lot of people in comparison to the list size? Do they prescribe a lot of medication in comparison to the list size? And we're able to map out practices, some of whom were high prescribing and low referring, some of whom were high referring and low prescribing, and basically all quadrants. Perhaps the most concerning were practices who were low prescribing and low referring. Now that isn't the kind of thing that will jump out on dashboard KPIs, but it's absolutely central and core to delivering an equitable provision, and that's what we hope to do within Trafford. And we found that actually in the north, a lot of practices who were there were relatively fewer GPs, and actually deprivation-wise, there was a much higher level of deprivation in those particular super output areas were relatively low referring. There was a lot more. West's the highest referring area relative to list size. Central is about what you would expect. South is slightly less than you would expect on list size, and North is considerably less than you would expect. And I think that that those are things that once you've got the data, you can do something about it. But you need time to monitor and to have initiatives in place. And I'd say that some of the London boroughs that Kate has worked in and brought some of that kind of good practice with her, one of the things that promotes or removes some barriers to referrals in deprived areas or areas with increased ethnicity is promoting self-referral, and that's what we're really trying to actively do via the best means and the best resources, really.
Thank you very much. It's Councillor Taylor next, and I'll just notice who else I'd like to ask.
Thank you so much. Can I just ask a little bit more about your self-referral methods? Because I've looked at the website and I would say it's not necessarily the easiest to find and navigate your way around. I know of the other IAP services in the Northwest that I would say are a lot more accessible. Is that something you are looking to address? And also thinking about, I represent a ward in the North that is very diverse, multiple languages spoken. Is that something that you would be considering when developing access?
In terms of the online referral, I'm glad you've brought that to our attention. I wasn't aware it was so difficult to sort of find and navigate, so I'll certainly look into that. We also accept paper referrals, so if people ring into the service and are just inquiring about how to make a referral, we can direct them directly to the online way of referring, or we can send them a postal application form. They can post that back or walk in and hand it into the team. So that's the ways of doing self-referrals. In terms of other languages spoken, we have some material which is written in other languages, and that's something that we're always looking to develop further.
Okay, thank you. So I think it's really important, isn't it, that services are culturally suitable for a wide range of people, and I think, the fact that it's all online maybe assumes that people can work with the digital platform and it's all written in English and things like that. That's not necessarily how some people would want to access a service, really. So I think that's something to really consider, considering the North is the lowest area of access as well and has the most culturally diverse population. I think that's something I would like to see looked at, really. Thank you.
Just to add slightly to that, of course there is access to translation services.
Yeah.
I acknowledge the limitations of that, but I'd also just add that we do also separately commission exceptional needs. So, for example, if people are hearing impaired, we can commission particular bespoke solutions for them so they can also access therapy.
Do you have a policy about translation as well, about who provides that? Are do you have professional translators who provide that service, or would you allow somebody to say come with a family member? What's the policy around that?
Yes and yes, basically. It depends upon what the person is seeking help for. I can't remember the proportion, but there are a large number of sessions per year delivered with a translator, with the accommodations needed to, extended time, etc., to do that. We often try to engage family members anyway as co-therapists if it's appropriate to the nature of the problems being addressed. And so sometimes that works very well. And I think also we've got, I can't remember the name of the Kate will know more than me, but the translation service that we do, but we tend to have the same people who are experts in particular high prevalent languages, and I think that really helps over time.
Absolutely,
because it's the subtleties and the nuances of the communication which are really vital in terms you're effectively helping somebody try to understand the subtleties of their own interpretation of their own experiences, and it's very easily misinterpreted or done badly, really. And I think so. But it's common practice. It's routine. However, I don't know how many per day we have, but it's usual practice now.
Okay, thank you.
Thank you. You referred to the increase in depression and anxiety overall, and so my question is really about the use of technology that you mentioned, and really thinking about it in terms of young people suffering with anxiety. I think it's more anxiety than depression from my experience as a healthcare professional, and I work with young people outside of Trafford. And there's a lot of I think the jury's still out is the expression when you say is social media good or bad for your health? And I was just sort of thinking about it in terms of you using the online therapies. Is that good? What is your experience? Can you talk a little bit about that?
Just to very quickly say, the context of this discussion and presentation is the adult IAP service. So just to say that, so we're clear. But in terms of, but within that service, there is absolutely online accessibility. So I'll hand over to colleagues.
Sorry, I know that, but when I say young people, I mean they become adults at 18, don't
Absolutely.
they? Become into your, and I know that a lot of people, young people at 18, young adults, sorry, I should rephrase, use that. So I'd just like to know a little bit more about that.
Absolutely.
There is online provision of therapy, evidence-based packages, and kind of gaps or kind of some innovative options delivered by our colleagues in self-help primarily. What we've done for the rest of the pathway in Trafford, there are two relevant points to the question you ask. We're trialing at the moment effectively a portal of apps, which is, the name of it is Orca, but it gives access to a whole range of both free to use and funded digital applications to either to be used as a standalone intervention to facilitate self-management, or to supplement the intervention that's being delivered by the counsellor, the psychologist, the CBT therapist, the PWP who's working with the person. That process, that's going to be delivered right across the 4 boroughs that we provide psychological therapies into, and we're currently reviewing and making sure that we get the best combination of digital materials, including digital materials that we hope to fund to give people free access to. The other relevant aspect that we've trialed, because there is an absence of evidence. I mean, our raison d'etre, if you like, is about delivering evidence-based practice. It's kind of, prove all things, hold fast up, which is good in terms of the Trafford motto. That's what kind of drives IAPT nationally. It's that's the philosophy of NHS psychological therapy at the moment. There's an absence of evidence of the effectiveness of a whole range of different interventions that appear very useful and a good way of trying to reach people, or just to make make it more convenient to access. So we've trialled a text talk therapy provision in Salford and in Bolton in the last 6 months, and we're just looking at the results of that. If that's something that's proved as effective as the glossy brochure suggests it will be, then that's something that we'll use in Trafford as well. But we don't wish to rush headlong into just delivering things because they're cost effective to deliver or convenient to deliver. We want to make sure that what we deliver is likely to be effective, or is most likely to give people the best chance of understanding and changing the difficulties that they're experiencing.
Thank you for that answer. And I'd be interested if you come back to us when you get some results and tell us more. Thank you.
Thank you, Councillor Acton.
Thank you, Chair. I'm really pleased that we have actually reached 21%, and that's congratulations to everybody. And a lot of good work has gone on to achieve that. And we are at now the national average, I believe. I'm not an expert at all in this field, but obviously there are 80% who don't access the service. And in terms of effectiveness and cost effectiveness, I think your figures around the 61% showing significant improvements once they've completed the therapy speaks for itself. That and you've talked about the fact that those with significant problems usually then experience health problems. So in terms of cost effectiveness, it's cost effective to actually do more of this. And do we not join up in terms of the health service to ensure that by having better therapy, more therapy for all of those 80% who don't have it, then we'll reduce the health of many of those people, the general health of many of those people. I think the other point that I just wanted to touch on was the deprivation which Councillor Carr was talking about, because it seems to me that that's where we should be targeting much more in terms of our communications and everything else, to make sure that we are tackling the problems in those areas, because we all know about health inequalities, and we all know that people die, in those deprived areas 10 years before those in the the well-off areas. And we all say that we should be doing this, and the figures don't show, in terms of your figures, that we're getting to those people who actually need it. So there are 2 points there really about cost effectiveness and joining up the health agenda really, and also the deprivation issue.
It won't surprise you hugely to hear me say I agree. As a mental health commissioner, I would say that
I thought you.
Oh, absolutely, absolutely. Trafford CCG is committed to delivering the 5-year forward view, and it's committed to delivering the long-term plan. So we are committed to that. We're also, I think, absolutely. I think you're absolutely right in the sense that if you can really help people with their psychological support, the overall costs that are attributed to them in terms of health and social care systems are reduced. So there is an absolute incentive to do this. That doesn't mean it's easy, and it doesn't mean we're in an easy place. We're not, but we're working extremely hard to understand that. And I think, one of the key things around that will be to really understand how we work at a granular level with individuals, with communities, with families, and we get to really understand what needs are on the ground. And I think that's our thinking in terms of how mental health needs to perhaps shift and change over the next 4 or 5 years. My personal view is I think we need to be looking much more closely at the positive collaborations between statutory health services and our voluntary services. I think we're seeing a hugely positive move in the primary care service because we've brought a third sector organisation in. That's shifting culture, it's increasing access, it's making all sorts of very, very interesting moves. So I think you're absolutely right. The challenges are big, but I recognise them, and we are doing our very best to meet them.
So Councillor Hartley first, if that's okay. Thank you.
Good evening. Thank you all for coming, and thank you to everyone who works, both in the commissioning and the provision of these services for improving the access rates in what's a very difficult set of circumstances, I know, and you've described. I've got some questions about the referral pathway and the treatment pathway, I suppose, and it's based on a flowchart that we've got in our document pack, which I don't think you've all got, but it's taken from a presentation, which I think is Dr. Hewitt, Dr. Thomason's presentation. You probably know what I'm alluding to, and so that sort of shows the referral coming in, and then there's I assume some assessment or triage as to whether it meets the service criteria. So my first question is just what that initial assessment involves, really. Is it face-to-face, telephone, etc.?
For most people entering, we deliver psychological therapies in a stepped care model. That's what we're required to do in IAB services. And what that means is that you try to deliver the least intensive intervention that's likely to facilitate meaningful change for the person. So it's more facilitated self-management to more intensive, longer therapy, a longer continuum. Most people enter the service through step 2, which is the low intensity provision, either in self-help or the majority in the integrated step 2 provision that we have. Most of those first appointments, unless the person specifically wants to be seen face to face, is an initial telephone appointment. And they're designed to do a few things. Again, a kind of, if you like, a problem definition, the person's own sense of how they see the difficulties, what their own therapeutic goals is. There's a brief risk assessment in terms of being able to see somebody or hear and ask questions within a week, a couple of weeks, in terms of to gauge where they're at and to decide and link them into the most, I suppose, likely to be effective form of therapy. Most people remain in step 2 and go on to have complete their treatment in step 2. Round about 35% start in step 2 and are then stepped up to step 3. But we run what we call an allocation model of step care. So not everybody has to go through step 2. If either at the initial paper screen and exercise or because the person's known to the service, they may go directly to step 3 or directly to our step 3 plus provision, which is for people who are experiencing a greater number of difficulties or longer standing difficulties, should we say.
I think you've probably sort of answered my second question, which was going to be about sort of the flexibility of the different therapies that are available. So you've talked about the sort of stepped approach. I suppose what I've got in mind, I'm sure as practitioners, you'll know a lot more about this than me, but I suppose what I have in mind is my understanding is that some therapies will work for some people and not for others, even though they may have the same sort of diagnosis. So somebody with severe depression, a CBT may work for them, or it may not work for others. Likewise, counselling may work for some and not for others. So as well as a sort of stepping up, is how much flexibility is there around the type of therapy somebody gets? So if they find counselling isn't working for them, is it easy to be rerouted into CBT, or do they, I suppose the bad scenario would be if they got discharged and had to re-refer, or that sort of scenario is what I've been looking to avoid.
The jargony term for it is stepping across, and it's common, I'm afraid. We're all of our processes are geared towards trying to get the person to the right destination at the right time for a variety of reasons, but mainly efficiency. And the last thing we have to deliver step care, but we still don't want people to have that initial experience of ending up in the wrong place and being moved, because people fall through the gap. I suppose characterized or give a pen picture of the typical difficulties somebody's experiencing when they enter the service. If they tell their story to somebody and then it's basically they're in the wrong place because of the nature of their difficulties and then have to move, there's a greater risk that person will drop out before the end. but we do step across primarily between counselling and CBT, or within the range of evidence-based therapies that we provide. So, for example, if somebody is referred with a post-traumatic stress disorder, either because of childhood events or a one-off adult event, they will go straight in at step 3, and more often than not will have a trauma-focused CBT intervention. Now, if that doesn't sit comfortably with them or is proved ineffective, we have another evidence-based option called the EMDR that they may be stepped across to. Or that same person looks like they've got a PTSD. That's what it says on the referral. That's what they describe when they've met somebody. We meet with them, and actually it turns out not to. It's they're traumatized by their experiences, but they're not having the intrusive re-experiencing and the anxiety, the phobic anxiety that characterize PTSD. It may be that actually what they want is more of an opportunity to think through and understand the impact upon them of their experiences, and they'll be stepped across to counselling. Or the same person has the PTSD, but they also have, childhood trauma. They also deliberately self-harm. They also got a substance misuse problem. They've also got a lifelong history of worry. They're also severely depressed. They will still be seen within the service, but they will be stepped to the step 3+ provision.
Thank you. And the final question, if I may, Chair, is so again, I suppose it's about it's more about the I suppose the coordination of care for the patient or for the user. So I suppose what I'm thinking of here is I know only 30% of people of referrals are from GPs, which is not a bad thing. Self-referral is obviously a good way into the service. But regardless of the sort of source of the referral, I'm wondering how much liaison goes on between the services and somebody's general practitioner, because I know, again, there's probably a range of clinical views about it, but I know some people with significant depression or anxiety may struggle to engage with the talking therapy unless they've had some other intervention, so antidepressants or medication. So obviously somebody may come to you as a self-referral, and I'm just wondering what sort of liaison assessment goes on so that you can tell the user, actually, you need to go and see your GP, and medication might help you initially before you move on to a talking therapy.
So with all referrals, including self-referrals, we routinely write to the GP. So they'll have a letter as soon as they've accessed our service and with the outcome of the initial telephone assessment. We will also routinely write to the GP after the assessment period and at the end of treatment as well. We also routinely write to the GP to notify them of any changes to risk. And we make recommendations such as maybe to review medication. And we try to facilitate any other agencies that might be useful as well. So, for example, if someone is on medication but they would like a medication review and that isn't able to happen with the GP, then we can try and refer them to see a psychiatrist for a psychiatrist review. So we routinely would keep GPs in the know with what's going on.
Councillor Dr. Carr.
Thank you. I just had a question about some of your service users. Now, 30% of your service users are men and 70% are women. But sadly, we know that most completed suicide is in men. And I just wondered what your approach is and whether you do anything specifically to improve access in men and to target that group, really.
Yeah, if you look at the proportion of service use and psychological services nationally and generally in Trafford and the other services, it's usually closer to 60-40, which still isn't, and I absolutely take your point in terms of help seeking and successful suicide disproportionate rates in men. The 70-30 came out of the caseload survey data that was included in the presentation, and it's alarming, and it's you get if you look at age, for example, you get a peak 30, 40, 50s. We've got a reasonable representation of people in all of those decades, so to speak. But younger men in particularly, and older men in particularly, we're not representative of the population, and there's no reason to believe that there's a less prevalence of anxiety and depression related problems. And I think, some of the things that we've tried to do to reduce stigma has been, and it's something that needs to be continually done, I think, but getting the kind of materials in the right place. And we've tried to be as innovative as we can, whether it's sport clubs or supermarkets, wherever it might be. But it's been able to communicate it in a way that overcomes some of the prejudice which still exists, I'm afraid, in terms of help-seeking behaviour, which there are gender differences within. So it's something that we're aware of, as we're aware of other inequities in access, but it's hugely important, and not just I know in terms of recent examples, it's not just in terms of actual help seeking as well, but actually when people do actively seek help, underrepresenting or minimizing the true nature of the difficulties that they are experiencing. And one of the pieces of learning that we did a work and well project, which was greater Manchester wide, but it was based in Trafford in Urmston. And one of the bits of information that came out of that was actually going out through a different route to reach the population who would be suitable for the service, and that population were people who had particular unemployment characteristics. Because we weren't reliant on a referral coming in or somebody self-referral, they were actually coming in through employment advisors. They had a key worker working with them to support them in terms of a range of employment needs. And if anxiety or depression related problem was part of the obstacles to return to employment, they were referred into our Urmston-based service. There was a much greater proportion of men used that service. People who've been living with extremely disabling anxiety, primarily anxiety-related problems for decades, and who had, I think the average was one contact with mental health service over 20 years. So there's something about how you go out and get the people who are out there who need the service. And that you have enough time to balance those kind of initiatives with the headline-based initiatives that everybody wants you to focus upon. The access rates and the access time and the recovery and effectiveness figures. They're all exceptionally important. Being green on all of those things does not mean you've got the kind of excellent service you want to deliver. There are lots of other initiatives that you need time and space to work upon.
Councillor Taylor's first, please, if that's okay, and then you. Okay, thank you.
Thank you so much. This might be an oversimplification, this question, but I was just looking at the section on page 17 about recovery, and obviously you've had a vast improvement in your recovery rates, which is great, and to be congratulated on that. And again, this might be too simple. How is recovery measured?
Kate puts it much better than me, but it's the easiest way to remember it is either to neither. So you come into the service, at the first time you meet somebody, you fill in a validated questionnaire that measures anxiety, and you fill in a validated questionnaire that measures depression. There's a lot of data on that to indicate where the cutoff is between a score that's more representative of somebody who has a clinical level of depression or somebody who has an anxiety disorder. So if you score above that measure on either of those measures, if you score above on either measure when you come in, then you're effectively, you can then enter the recovery calculation. You've got a clinical level of distress. Those scores will be measured every subsequent session, because there's a high dropout rate, there's a high discontinuation rate in psychological therapy services. So we know what the recovery rates are for people who drop out and for people who complete planned treatments, for example. In commissioning land, they use the term, for treatment completion. That's the NHS England term for it, kind of that people have completed treatment. It doesn't actually mean that they've completed treatment. We've got 61% recovery on those figures for people who've attended at least 2 sessions involving treatment. So they've come along at least twice, basically. That is what it means, but a proportion of those people will have dropped out. So if you like, we measure it from the very first session, the in the clinical range on either, till the last session they're on the clinical range on neither. So it's kind of is the way I kind of bear it in mind.
So if they drop out of the clinical range, then do you class that as a clinically significant improvement in there?
Well, you're making this this is a whole new level on that as well, because recovery just means you're in the clinical range on either, and then you're in the clinical range on neither. But you could be in the clinical range. You could come in and score 10 and leave and score 9, and that would count as recovery. You could come in and score 27 on a PHQ-9 and leave scoring 10, and you're not recovered. However, you would have reliably improved. So if you move a score of 6 on a PHQ-9, you're reliably improved. And if you move a score of 4 on the GAD-7, which goes from 0 to 21, then you're reliably improved. So there are different measures of effectiveness.
Right, are those the two outcomes that you use then mainly?
Yeah. We have a question which is a real kind of eye of the beholder effectiveness question, which, to what extent is the problem for which you sought help being resolved through access and services, and kind of from not at all to partially, moderately, completely. So we know what those figures are for the service as well.
And have you included that in that report then, or not? Because that's probably more important to the individual, actually, isn't it? Yeah.
It absolutely is, and that's what we've just had an improvement on our IT systems specifically for all of our IAP services, and we're going to be able to report down to an individual practitioner level, and that's the data we're actually going to report back to practitioners and to teams. 72% of people who you've discharged this year have said they've completely or mostly resolved the problems that they present with. And that's actually a much more validating message to hear as a staff member.
That's success, isn't it? Yeah. Can I just ask? Oh no, I better not ask any more questions. I'm getting the look now from the chair. Best not.
Councillor Lloyd, thank you.
It's good, the recovery rate, but how many people actually come back into the system, and how often?
I can't give you the numbers, but what I would say, and I'll precede that by saying that this is actually something that we need to encourage. My guess is, of the people who use our service, around about a third of people will have a one-off contact with the service. If they get the kind of intervention that they need, it'll be a one-off. Round about a third of people will have intermittent or episodic contact with the service over the years. If you attract people for long enough, they would come back at some point. And round about a third of people are living with long-term anxiety and depression related problems. And what we want to do with that population is actually encourage them to access the service intermittently. Now, partly that's because that's often what the individuals need. They need some kind of top-up intervention to help them understand the impact of worry upon their life. What they don't need necessarily is repeated prescriptions or repeated contacts with health services or repeated referral to acute services to manage their distress, when they may well be at the end of sensible medical intervention for the physical conditions that they're presenting for, but they're still in distress and they need that support and ongoing help. So we deliver a kind of learning-based model, and the nature of some anxiety disorders in particular is that unless you get access to effective intervention, they're not going to spontaneously remit. With depression, it will spontaneously remit. You can pop out of the other side of it without any effective intervention. For an antidepressant to be really effective, it's got to do better than 40% recovery, because 40% of people will just pop out of depression anyway. So we will have, and I can't give you an exact proportion, but we will have a proportion of people who are using the service routinely, whether it's every year or every couple of years. And actually that's exactly what those services are there for that percentage of the population.
So how many of those, presumably the people who are in long-term, are they on long-term medication? Because you would presumably give them medication for that.
We don't prescribe any medication.
You
but
just do the psychological therapies.
Yeah.
But if you've been to the doctor first, will they be on medication before they come to you?
Oh, most people, the average length of time that people, this is the average, the mean length of time that people have had difficulty to use the service in Trafford is around about 5 years, I believe. We'll have a large proportion of people who've had lifelong problems. Most people have come with multiple trials of different antidepressants or anxiolytics or hypnotics or combination of major tranquilizers and all sorts of medication combinations that haven't resolved the problem. Sometimes they've alleviated distress, sometimes quite significantly. Sometimes that, as your colleague pointed out, sometimes that joint approach is essential and to be indicated. But actually most of the first line, if you look at NICE guidance, if you look at best practice guidance, most of the guidance will not tell you to start with an antidepressant or not tell you to start with an anxiolytic. It will tell you to start with an approach that helps a person understand the nature of what they're experiencing and learn some self-management skills.
I understand that, but I'm not sure that's out there in practice.
No, I don't think
and
it
in
is.
fact, actually, I know it isn't.
Yeah, I know.
Thank you. Councillor Akinola.
Hi, can I ask what happens to people, because we know that there's a lot of younger males don't tend to be signed up to a GP. So what happens when they access services, and also where does social prescribing come into it? Does it?
Social prescribing absolutely does come into it, and that's the profound link I think we're beginning to build to the primary care service. So not only are we making sure that people are accessing clinical services, we're trying to help people access voluntary sector services, but also provide opportunity for them to become volunteers and actually to deliver sort of meaningful help to others. So the social prescribing, absolutely. In terms of people not being registered with GPs, I mean, there are very clear rules in terms of how one would judge whether that person was able to receive services here, and if they were, they would absolutely be able to access any health service in Trafford. It's normally done on a residency basis. Do you get? I don't know if you get many referrals through for unregistered patients. We can certainly look at that and find that out, and I'll also, Councillor Lloyd, have a look at your question and see if we can get some data for you. But
can I just ask, is social prescribing, is it all done through GPs, or can people who are not on a GP actually access it as well?
The primary care service at the moment is working in various ways. In its first year, because we are trying very carefully to make sure that the capacity isn't overwhelmed. So at the moment, it is mostly a GP referral service, but we are absolutely committed that if we are able to expand that service, its access routes will change and become much more varied. We're already closely working with the Let's Talk initiatives in Trafford. So we've got non-GP referral routes coming in that way from council colleagues, which is absolutely brilliant. But we desperately want to be able to expand that to leisure trust, to ambulance, to police. We would love to expand that, but we're just mindful at the moment we've got a limited resource. If we overwhelm it, I think we'll reduce the quality unacceptably. So I think that's definitely something we want to do. But at the moment, it's slightly wider. I think the other thing about the social prescribing is that as that grows as a way of us working, it will of itself begin to identify people who can be encouraged to access services. So I think the thing for me is the people who are in contact with their GPs going and saying, I need help, in effect, we've got lots of services for those people. It's the people actually that I don't know where they are. They're in their bedroom somewhere. They're isolated. They're lonely. And the only way we're going to reach them actually is by creating mechanisms of social contact and friendship and support that we haven't quite yet got, but we're building them. And that's where the integrated services that we're working so hard to create between health and care is profoundly important.
Okay, thank you. May I ask one question myself? So, really impressed at the increase in access to the service. That's excellent. But obviously, I think, as you said at the beginning of your presentation, that for every 90 patients that you bring into the service, you need one new professional working within your service. So, obviously, you're seeking to improve access. We hope that you're going to be improving access in the north. Could you please explain to me more about your capacity to deal with any increased access? It's good to have it, but then if you can't match it and have the services to ensure that it's met, then it's a worry. And so my query is really about what is the limits on your capacity and on funding. How do you gain extra funding? Thank you.
So I'll just start with a brief answer to that. The limit on the capacity at the moment is the target that was reached, so the 19, 20, 21%. We have a business case that we're currently considering that will allow an increase in capacity in order to meet this year's targets, and that's just under consideration at this very moment. I don't know if there's anything to add to that, but
I mean, I suppose for everybody else in the room, the way that it works is that the CCG have their targets in terms of how many people or what proportion of the population they're expected to demonstrate that they deliver or commission psychological therapies for. They have provider organisations that me and Kate work for, who deliver those services. To increase the amount of funding to enable us to increase the workforce, we need to write a business case. There's usually some consultation or kind of work with the CCG beforehand, and then we'll ask Rick very nicely for X amount of pounds and demonstrate what we think we're able realistically to deliver for those X amount of pounds. I'm very conscious of the economic climate, locally and regionally, nationally, and it's extremely difficult. And I think everybody wants the same. Everybody wants the best quality service that we can deliver locally, and that's what gets us up in the morning and drives us. But to do that, it's a constant struggle to make sure that we've got the conditions in place, and that's not just scraping enough staff to ensure that the access time remains okay and that the access rate remains okay, but that the services are person-centered and flexible, and what we're doing initiatives to go and reach the people that we need to, that they obviously remain safe, and that we do things efficiently as well as staying timely and effective. So you can't get a quart out of a pint pot is a familiar expression from somebody who used to be a commissioner in Trafford, and it's true. So we need, or the provision needs to be wide enough. It all doesn't need to come from NHS providers, but it does need to be evidence-based psychological therapies, because that's what is meant to be commissioned, and that's what trust me, that is what the people, or a high proportion of the people, need, is something that has got a really good chance of facilitating meaningful change. But we have a lot of third sector voluntary organisations that we could link in better with, and that's going to have to be part of the solution as well. For that many people, for 28,000 people, whatever it might add up to in terms of 31% of the prevalent population, to enter therapies in Trafford, we're going to need to be really creative in how we go about doing that. But we do need to have some, it's the NHS constitution says we should be delivering services in the way that we want a loved one to receive it. And I think that when you know what the likely effectiveness is of particular interventions, that should be the design principle. Is that what you'd be comfortable receiving yourself, or that you'd be comfortable for one of your loved ones to receive if they were presenting with that kind of presenting problem? And that's the test. Not how many of these can we have for that amount of money. It's actually what is going to be likely to be effective. And that's going to be a continual challenge, as well as having somewhere to put those people to deliver those therapies.
I hope the assurance is partly in the presentation, because I think the fact is that the Trafford service has been of really, really high quality for a number of years. It had a blip. You are absolutely right to identify that blip, but the quality has been good. Our commitment is absolutely to maintain that quality. I think it is more than money, but we're committed to finding the money if we possibly can. But it is more than that. It has to be the parity of esteem agenda. I think is really important. So it is equally, how do physical healthcare services start thinking about the provision of psychological support? How do they help us identify patients? How do they help us in providing co-location opportunities? How do we maximise the voluntary sector contribution? So I think there's a whole range of things that go slightly beyond just putting another lump of money into a particular service, because actually sometimes when you do that, you keep that service in a silo and you reduce the opportunities for integration. But we're absolutely committed to maintaining that quality.
Thank you very much for that very helpful response. I think given the time, we better close the discussion for this evening. But thank you so much for coming this evening, for your valuable reports and for updating us, answering all your questions. We're, as a committee, incredibly grateful. We just have one request. We are planning to ask our contributors over the next few months to return in March for our last meeting before the end of the municipal year. We just wondered if you would be happy to return to update us just on the things that you've recognised that need attention or that you are about to improve, etc. So a couple of things I made a note of was progress with access in the north, the review of the website, more information on relapse rate and how you deal with attrition rates and referrals for unregistered patients. Just a couple of things that I've picked up in the discussion, but absolutely anything else that you feel you'd like to feedback, would you be happy to return in March?
Absolutely delighted. Yes.
Oh, that's absolutely fantastic. Well, thank you so much for that. I'm really, really delighted, and thank you again for coming this evening. Thank you.
Thank you very much.
Thank you.
Thank you. Okay, so I hope it's okay to just carry on with the agenda given the time. Our next item for discussion is the Trafford Suicide Prevention Action Plan and Strategy. Oh, thank you very much. We have two public health physicians, I think, going to talk to us. That's very nice. Thank you. And our representative from the Samaritans, which is absolutely wonderful. Thank you. So thank you so much to each of you for attending this evening and for sitting through the first part of the agenda, which may, in fact, kind of be interesting for this discussion as well. Would you just mind, for the committee, just introducing yourselves?
Yes,
Thank
certainly.
you.
Thank you for inviting us. I'm Ben Fryer. I'm a public health registrar in the public health team here at Trafford Council.
I'm Donna Sager. I'm the new consultant in public health. I've been with Trafford for 3 weeks, but I've worked most of my public health career in Stockport.
Okay, and I'm Robert Jackson. I'm director at Manchester Samaritans.
That's fantastic. Thank you. So have you decided between the three of you who would like to speak first? Okay, thank you. Is that okay with you? Is that okay?
Yeah.
Fantastic. Thank you.
Okay, so thank you for inviting us to speak to you today. Suicide, as I'm sure you're aware, is a really important public health issue. There are around 6,000 deaths through suicide every year in the UK, and suicide's been identified as an important issue for the NHS through the 5-year forward view. Within Trafford, we mercifully have a lower suicide rate than much of the rest of the Northwest, and indeed the lowest in Greater Manchester. But that still means that we see around 15 deaths through suicide every year. That number's declining slowly over time, but there are things that we can do to help that number decline further and decline faster. Suicide can affect anyone. It can affect people at any age or any time of life, but most suicides or a greater proportion of suicides occur in men aged 35 to 49. There are a number of risk factors that explain why some people are at higher risk of suicide than others. We know that suicides happen more often to people who have self-harmed, people who have poor mental health or poor physical health, people suffering a relationship breakdown, people in insecure jobs or in particular industries, people with debt, people who have a range of other financial issues. But we also know that suicide is very unequally distributed in our community, and that people in our more deprived communities in the north and the west of Trafford are more likely to die through suicide than people elsewhere. Within Trafford, we have recently benefited from the time and input of a clinical psychology trainee who has worked with us within the public health team and with a really wide range of partners across Trafford, including statutory provision and voluntary sector partners, to develop a new suicide prevention strategy. That was developed through a workshop with some 40 or 60 stakeholders represented. And so we now have our first suicide prevention strategy and action plan, which has been shared with the meetings today. We have also set up a wide partnership group which will support us as we implement that action plan and continue to steer the work that we're doing on this topic. Our key early priorities on that action plan involve raising awareness of suicide, reducing the stigma around suicide, and encouraging people to talk about this really important issue. Training staff within the council, but also in some of our partner organisations, to appreciate when people might be thinking about suicide and to be brave enough to ask the questions that can help connect people to the support they need to think that through and to recover from things that are causing them to consider suicide. We're also working closely with our coroner, which is the Stockport coroner, to understand more about suicide within our borough by receiving real-time information. So 1 or 2 days after a death occurs, we now are notified of that death so that we can understand whether there is focused work that we need to do with particular communities that might be affected by a suicide, but also working with our GM colleagues can ensure that referrals are available through the GM Suicide Bereavement Information Service to services often in the voluntary sector that can help people who are left behind.
Thank you so much.
Thank you.
Just a couple of comments, Chair. I think it's really important that we're aware of the range of work we're doing and also how we've modelled some of our programmes and actions on the evidence base, because it's a very important area to continue to investigate. And also some of the comments that colleagues in the previous presentation provided us with showed that suicide prevention is everyone's business, and that there are clearly groups who are at higher risk who might be in contact with our increased contact with our other services. So our work as well is about supporting frontline staff to be aware of those issues and to be aware how to respond to those in a constructive way. I suppose really the third point is that, and it was a question that colleagues were raising around media awareness. There is a lot more, I think, now media awareness around suicide and suicide prevention. And I think hopefully some of those messages that are going out will enable us to be able to identify and to bring to people's attention the many sources of support that are available, both within the statutory and the voluntary organisations, and particularly our colleagues here in Samaritans.
Thank you, and thank you for inviting me today. And it's particularly, your interest in this topic is particularly relevant now because the suicide figures, the most recent suicide figures, do show quite a dramatic increase since 2013. So the 2018 figures are quite a bit higher. So this is a very timely concern. I work at the Manchester and Salford branch, which is just opposite the Palace Theatre in town, you may know. There's 200 volunteers in the branch, of which we have about 160 in the branch, but we also have 40 prisoners across 2 Manchester prisons who are Samaritans, who do Samaritans work in prison on their wings. So we have people actually in those prisons, which is a high suicide risk environment, and they are doing our work in those prisons with their peers. The line is 24 hours a day, it's free, it's confidential, and Samaritans are ordinary people who give up their time to listen, but by listening they have an extraordinary effect, and our aim of the organisation is to reduce suicide, and we do that by easing emotional distress at whatever level it comes at. Some people who ring us are in absolute crisis, about to take their life or in the process of taking their life. Some people are at the other end of the spectrum, but their concern is a concern for them. So we ease emotional distress at whatever level it comes at, and we do that by making people feel heard, by making people feel connected with another human being, by giving people the chance to tell their story out loud, the bit that's concerning them. And as they talk out loud, they begin to understand, and the emotional distress is eased, and hopefully they will think of their circumstance in a different way and perhaps change the next few paragraphs, hopefully. Somebody calls the Samaritans every 6 seconds in this country. That's something like 13,000 people a day, which is a staggering figure. And just to think of taking the Samaritans out of the national fabric of our national life, it would leave a massive hole. There's something like 5.5 million people a year who contact us. There's 20,000 volunteers, over 200 branches, and somebody takes their own life in this country every 90 minutes. So since we've left home this evening and arrived back home after this meeting, somebody in the UK will have taken their life, which is a staggering thought. People ring us with all sorts of issues. The top sort of category of issue is isolation and loneliness, family and mental health issues as well. And 1 in every 4 calls, suicide is discussed at some level or another. As we've just heard, the risk of suicide isn't equal. 3 out of 4 suicides are men. Less well-off men are at higher risk. It's the biggest killer of men under 50. It's the biggest killer of young people under 20, between 20 and 34. And this last counting year, for the first time, there's been an increase in the number of young women who take their own life, which is quite concerning. Particularly vulnerable groups, as we've just heard, low-skilled, homeless, LGBT people who have mental health issues, military veterans, the homeless, new mums, people who've had a history of self-harm, abuse, construction workers. So it's not equal at all. And I think that list of, the list of people who are vulnerable to suicide does tell us quite a bit about who's marginalised in our society. As I say, the recent trends which have just been published do show an increase since 2013. And as I say, for the first time, young women have increased the rate of suicide. In young people, there had been a trend downwards, but just in the last year, especially with young men, the trend has gone up again. So there's interesting questions as to why that is happening. What Samaritans nationally are doing is business as usual, providing our service 24 hours a day and free, but we're also focusing on trying to home in on these figures and get into these figures and see if we can target particular groups who are more vulnerable. So we're trying to work out what actually works with these groups in terms of accessing men particularly who are not keen to come forward, looking at the impact of inequality and what is it about the people on that vulnerable list that is making the move towards thinking of suicide. We're looking at online safety. We're doing a lot of work with the technology companies to make the online world a safe place for people to be. I'm sure we've all got concerns about the impact of social media, especially in grooming vulnerable people into all sorts of toxic behaviours. So we're doing a lot of work with trying to make the online community, the online world safe. We do a lot of work with the media anyway on reporting suicide safely. Not to glamorize it, not to give ideas, not to give a location. We're just starting up a new platform for people to communicate with us, an instant messaging platform. People can contact us on the phone, face-to-face, by email, by text, and soon by instant messaging as well. And we're also trying to set up an online sort of self-help tool, if you like. So for people who are just beginning to contact us, something that will help them reflect on their own self-care and perhaps signpost them to other offers of help as well. So we're doing a range of things on a national front. On a local level from our branch, we do a lot of outreach work with schools and universities. We go in to help students and young people develop their own emotional intelligence, develop their own listening skills. We go in post-vention. If there has been a suicide in a school or a college, we go in and support that community. We work with local community groups. There's a community group not far from here that's concerned about a cluster of suicides, and some local people want to become better listeners themselves. We work with we get referrals from A&E. When people who've gone to A&E with a suicide attempt, there's nowhere else for them to go. So we can pick up some of those cases with their permission, and we can ring them for the following few days to see how they're settling in after they leave A&E. We work in workplaces as well, raising awareness about the service and about mental health issues, about wellbeing in the workplace. We do training as well. We train various people on the Samaritans listening style, and particularly asking the suicide question, because all the evidence shows that asking somebody who has suicidal thoughts, it helps. But we sort of shy away from that because suicide is a difficult subject, but also there's this idea that if we ask somebody, it might give them the idea, but that is a myth. So we help people to be able to ask the suicide question in an appropriate way, in a step-by-step way. So when we involve ourselves in various bodies around the city, giving information about Samaritans and so on. So we do a lot of outreach work from the branch as well as taking the calls in the branch.
Thank you so much. That's an exhaustive list of things that you do. It's incredible. So thank you so much. Could I ask, do you work with the council at all? Do you?
Not this one, no.
Right.
I've done some work with Manchester City Council with their suicide prevention strategy. So yes, we have sat on various boards with them as well.
Okay, thank you. So would any of our members like to ask? Yes, please, Councillor Hartley.
Thank you all for coming and for giving us some really useful information, and the the report and the plan I think is really encouraging about the work that's going into suicide prevention. I had two questions that are quite specific, which I hope you can help me with. So the first one is I think, Dr. Fryer, when you were talking, you mentioned the relationship with the coroner, the South Manchester coroner, and it sounds like a positive relationship, and it was encouraging to hear that you get notified of a death, very, very promptly. Although I note in the report there is mention about difficulties with accessing data at the coroner's office, which I hope gets resolved soon. So it's really a follow-up to that point, really. If the relationship with the coroner is good and productive, and you get notified early, I wondered what sort of further sort of follow-up you get from the coroner. So I'm thinking if the coroner sends a Rule 43 report to an organisation about preventing a further death, does that automatically get copied to you, so you can think, actually, do we need to engage with other people about why somebody took their life in a particular sort of setting, really? So I just wondered what sort of follow-up comes later on from the coroner.
Thank you for your question. I think our relationship with the coroner is very positive, but it's a fairly new relationship and a developing relationship. We're working with as a group of 3 local authorities that are served by the one coroner, so Stockport, Tameside and Trafford. And we've initially started with the real-time alerting that's been mentioned in the report. We hope that work, which has only been going for a couple of months, will continue to be successful, and we have a series of meetings with the coroner booked in where we'll hope to build on that work. And I'll take that suggestion that you've made. That's very helpful. Thank you.
Thank you very much. The next question, which is a different topic, is about training for council staff, which is mentioned in the report, and it mentions Trafford will roll out a mandatory e-learning package on suicide prevention and skills. Now, I sort of always have a skepticism about e-learning packages that get rolled out to a whole organisation, because it gives you that baseline and gives you a baseline awareness, which I think is good. But in my mind, it's not a substitute for sort of more in-person, hands-on training to those staff that really need it. So I suppose my question is, in addition to that e-learning package, is there any in-person training planned for council staff that may encounter users who may have suicidal thoughts? And I'm thinking particularly, Mr. Jackson mentioned, the difficult conversations that you have to have, or that appear difficult, but actually it's just an open conversation about, do you have any plans to take your life? Do you have the means to do it? How serious are the plans? And that sort of, it sort of needs someone to see how it's done, to even hear how it's done through a recording of a call or a simulation of that. So I just wondered if there's plans to sort of have an enhanced training package for council staff who are most likely to encounter that.
You make a really important point. I think the first thing to say is that The e-learning package that we've rolled out within Trafford is a very recent package that's been developed with Health Education England. It's focused around a series of 5 interactive videos which do exactly what you talk about. So they demonstrate a conversation that might spark a thought, a concern about someone in a workplace, someone in your gym, someone in your pub, who you might be concerned about. And they show you what might happen if you ask them about their health, how they're feeling, whether they have thought about suicide, what support they've got, and what might happen if you miss that opportunity. And we've been careful to choose a support package for our staff that is sensitive to the staff members who are taking that package, because obviously they'll have a wide variety of different experiences themselves, but also make sure that it's a package that really helps people to think about suicide and how to prevent suicide in a positive way, and begins to develop the idea that people can make a difference and develop the skills that people will need to do that. In addition to that package, we've rolled out a package for managers within the organisation to help them to support staff who might have concerns or mental health issues themselves. And once the rollout of those packages has been going for a few months, we'll of course review what staff have fed back in the evaluation process and talk to staff to understand what more we need to do in this area.
I think just to add to that point, I've done the psoriasis training, and it is absolutely first class. It is very, very helpful. And I think it's about also expanding this to our partners. One of the key colleagues who I sat with when I did the training with worked in the job centre. And I was absolutely amazed at how many times they have people in absolute acute distress being delivered some really tough messages, with staff having to face the consequences of having some kind of engagement with their clients. And to me, it was very, very important that we cast the training net as wide as possible, because of those people who are likely to be experiencing this really significant distress at some key points in their lives. But the training is really strong, really strong.
Can I just interrupt about currently doing some awareness raising process? Because that's where policy meets people. And it is quite staggering. Some of the traumatic situations they are in. So we are doing some awareness raising at the moment.
Thank you. Yeah, I'm really encouraged.
Thank you very much. I'm just looking down my list, and the next person is Councillor Taylor.
Thank you very much. I think you've already addressed some of the questions, but I was really interested I was making a note of this, and then I saw encourage professionals to ask about mental wellbeing at every opportunity. Is that making every contact count? Which you've all said, suicide is everybody's business, isn't it? And it's really sort of embedding that in existing healthcare professionals across the spectrum, isn't it? Whether they be, medics or allied health professionals. And I'm thinking, how much is this embedded in undergraduate healthcare education as well? I mean, I work in healthcare education, and we talk about it, but I don't think to any great extent. And sometimes it's a really difficult question to ask, but it could be the most important question to ask, couldn't it, as well? So I just wonder what your thoughts are about that, really.
We'd entirely agree with what you're saying. It's really important that all health staff, but not just health staff who are interacting with the public, people who have an opportunity to support people, are able to ask questions about mental health. And really, for health staff to treat the whole person and not just the first condition that somebody attends with. We obviously don't have responsibility here for the undergraduate medical curriculum.
No, I know that. Yeah.
But I understand that the GMC has brought in some wider standards across medical training, requiring doctors in training in particular to look at public health, but also at mental health, regardless of which specialty they're training in.
Thank you. I think it's just a question. It's destigmatizing, isn't it? Because it's a very difficult subject to talk about. But unless we do talk about it, people are still going to have deaths. And I mean, one of your statistics here, it highlights, doesn't it? 3/4 of death are men, and many are not in contact with mental health services. So it's incumbent upon all of us, isn't it, really, to initiate those conversations, really, I guess. Yeah. Thank you very much.
Thank you. Councillor Akinola.
Hi, I've got two quick questions. One is, I'm glad to see that in the training you're talking about training security staff and hotel workers. One was, how are you going to do that? Because I'd be interested in the practicalities of that. And the other thing was, Samaritans, is there any way that you gather data with regards to sexuality, ethnicity, disability, and what sort of figures have you got?
We keep minimal records, but after every call we do sort of an outline, basically. So name, if we have one, gender, what the issue is, whether suicide has been discussed, at what level the suicide has been discussed, whether self-harm has been discussed. So we do collect some data set nationally, and that's collected, and I haven't got access to the detail of it, but yes, the short answer to your question is yes, we do collect data, and we try and respond to it. As the vulnerable groups that I've mentioned are the ones that we try and reach out to with various campaigns from time to time.
Suicide prevention is a partnership activity, and within the public health team, we see our role as facilitating a Trafford partnership of lots of different organisations that can do different things to help reduce the risk of suicide and to support people who are affected by suicide. And we work in a Trafford partnership that's also linked to the Greater Manchester Partnership. And some of the organisations you mentioned are represented through those partnerships, and that's how we would act to deliver the training. When we have worked with Health Education England to design training, have made sure that it's training that's fully appropriate for health staff and staff in the public sector, but can also translate well to other settings. And indeed, one of the key public sector organisations that was involved heavily in the design of that training was actually the fire service. So thinking about how a very different professional to the nurses, for example, would be able to deliver that support, very similar support, but from a different professional, and a professional who might be trusted and respected by a different bit of the population to the people who might respect and trust the nurse.
Thank you. Next person is Councillor Slater, actually, sorry. We'll get to you, Councillor Dr. Carr, I promise.
Thank you. Thanks for the presentation. What I wanted to just update committee on is that we've actually now started a suicide prevention group within the authority that is chaired by Councillor Harding. And we had our initial meeting a couple of weeks back, and we do invite Job Centre Plus. Obviously, with Ben comes, Rick is very kindly attends as well, and we do have the police involved, North West Ambulance Service, and quite a few others. But I think that obviously we need to extend the invitation to yourselves. I don't know if you were invited, but we can pick that up. So we are making it a really, it is a big topic for us, and the stuff that you were talking about around the staff and the staff training, because of the staff we're expecting staff to intervene and support people. We're going to involve the trade unions as well within that group, so that they can actually then support their colleagues, because I'm aware that trade unions now are actually giving stewards suicide awareness training. So those are things that we're going to be able to bring to that group. But I just wanted to let you know that that's what we're doing.
Thank you very much, Councillor Slater. I should have said that Councillor Slater is a visitor to our committee, but is here as an executive member for, I have to read the title, Health, Wellbeing and Equality. So thank you very much. That's really interesting. And I'm very pleased to hear that the Samaritans, you will be inviting the Samaritans to join you. That's really fantastic. Councillor Dr. Carr.
Thank you for coming in for your informative talk. It follows on from Councillor Taylor's point, really, that a number of people who do complete suicide are not in contact with mental health services, but a number of them have seen their GP in the short time before they commit suicide. And indeed, that was the case for my close friend who did commit suicide. He had seen his GP only 1 week before. Now, the problem for our GP colleagues are that, they have a 10-minute appointment. All that we've done over the last few decades is close inpatient mental health beds, and we've told them time and time again not to refer. So what are we doing really to allow our GP colleagues to be able to triage those patients that they do see in that crucial period before they commit suicide? What tools are we giving them, really, and what part do they play in this suicide prevention strategy? It isn't a common thing in Trafford, but a lot of these patients have seen, a lot of these people have seen their GP, and what can we do to try to make that GP know where to go and how to best get help for that patient in a really crucial time?
Firstly, I'm sorry to hear of the death that you mentioned. Within the Suicide Prevention Partnership Group, we have representation from many of the key mental health services across both the statutory and voluntary sector within Trafford. And we've already heard from Rick Taylor in the CCG about the work that he's doing to ensure improved access to psychological services. We've also, within the suicide prevention group at the Greater Manchester level, set up a website, Shining a Light on Suicide, which provides a directory of a wide range of services, mostly in the voluntary sector, that are available to support people. And I think it might be useful for us to take an action to communicate out to GPs to make sure that they're all aware of that resource and the excellent services that it links to.
So in my previous post, there was some specialist training that was available from GPs, so for GPs. So I'll make some contacts with where I used to work to see what support is available and whether those training providers could come to Trafford. And I'll do a bit of digging on that one. Thank you.
Councillor Haddad, sorry.
Hi, good evening. I was just wondering, talking about raising awareness and your suicide prevention strategy in Trafford, I know you'll probably be aware of the mental health first aid training courses and the different levels. And, I've actually completed one of the courses, even though, I'm a general nurse trained. I found it quite interesting because, there were lots of people there that weren't professionals and how beneficial they found it as well. I wondered, how does that figure in your raising awareness? Does it figure in your strategy? Is that something?
We have mental health champions within the workforce in Trafford, and where staff are trained up, and it might be something that we can look to spread wider, but we do have those champions already.
I was just wondering if it figures in the strategy that you talked about here over Trafford, because I know it talks, the training is different levels, but they do talk a lot about self-harm and suicide within the training.
I think that's a really important question. We have, within our strategy, chosen to focus on a course that can be accessed by all staff and spread a really broad awareness within Trafford's organisations of the importance of thinking about people's needs and being open to talking about suicide. I think once we've done that, we will need to move on to how we enable more people to be able to provide more support within our organisation and more broadly within the community. But I agree that it's a course that's really important. I know that the CCG and Council have funded some staff to go through that course this year, and we'll be sort of looking to see how those staff have found that course and how it fits in with our plans going forward. Thank you.
Be useful to, if you get any feedback, if you get any thoughts further on, to let us know about it. Thank you.
We will. Thank you.
Okay, thank you. If I may ask a couple of questions of my own, I'd really appreciate that. So one question I had was about the role of you say that 2 counsellors have a responsibility for, I think it's for suicide prevention within the council. And I know that Councillor Slater has explained one of the councillors, Councillor Harding, chairs a prevention group, yeah. So what does the other councillor do? Is it yourself, Councillor Slater? And can those councillors cascade the information down to all 63 councillors? Because obviously I think it's, as we've said, it's everybody's business. And is that something that would be possible? So that's my first question, please.
Both of the councillors who are involved are members, one of whom chairs that suicide prevention group, so have broadly similar responsibilities in this work, and I don't see any reason why that information shouldn't be cascaded. We'll encourage that to happen.
My second question is really to do with the opening of the UA 92 that's coming on stream soon, isn't it? And we know that obviously university students are incredibly vulnerable. And I just wondered whether you were going to have links in with the UA 92. Are you going to include them in your partnership? Have you made any approaches, and just kind of a little bit more information about how you're going to be reaching out to students? Thank you.
We're more than happy to start circulating and sharing outcomes from that group with all the councillors. And we, as part of the board that we've set up, we are going to invite UA 92 to be involved in that so that we can support them as well.
Well, thank you very much for that. And then my final question is, I'm really delighted to see that the Samaritans are going to be included in our board. I think that's wonderful, and it was on my list. But I just wondered, obviously, debt is a big issue for people who are kind of feeling depressed. It can really, really make you depressed if you're in debt. Have you considered reaching out to the CAB? I know you've got DWP, but not everyone is going to the DWP. There's the CAB and other kind of voluntary organisations. Now you've got good representation, and you can't have a massive group. It's got to be reasonable. But are you thinking a bit more laterally about who else you might invite? Thank you.
We are inviting the CAB, and it is much wider than the group of people that I said. The meeting had as many chairs and there's people in them. The first meeting, and also we're going to talk about inviting the credit union as well, because if people get loans from a credit union as opposed from a payday loan company, then actually when they repay those loans, their credit rating increases, which is better for people. So we are looking to invite the credit union along to those meetings as well. So we are talking about financial poverty as well in those meetings.
And if I may add to that, within the group members that we already have are represented several organisations, including the council and the housing trusts, that have functions where officers have to follow up on people who haven't met their bills and are thus in contact with people who are in significant debt. And one of the key things that we want to ensure is that when those conversations around debt happen with people, the mental health of those people and any possible suicide risk is taken into account, is thought about, is considered, and some sort of risk assessment almost is done, so that if debt is something that's leading people to think about suicide, that those needs can be understood, addressed at those times.
Well, thank you very much. It's really great to hear that there's such positive input into your partnership. Are there any more questions around the table? If not, I'd like to thank you all. Don't just fit quite yet. Just to say thank you so much to all three of you for sparing so much of your evening this evening, for preparing the reports, for our Director of Samaritans. Thank you so much for giving up your very valuable personal time to come this evening. And I just wondered, as with the previous presenters, would you be happy to come back just for a very brief presentation to update us on some of the things we touched on? And I'll just remind you of a few of the things that I noted. Maybe progress on the meetings of your board, your group, that'd be fantastic. Any updates on your strategy and action plan, and feedback on e-learning, whether people are actually taking it up, what the feedback is from that, and any of the other issues that you said you would be happy to respond to. Would that be okay? Would you be happy to do that? That'd be absolutely amazing. Thank you so much. I really appreciate your time this evening. Thank you.
Thank you.
Okay, so just moving on to our, I think, final report of the evening, which is, I can't find my agenda, but I think it's, yes, it's, I'm just trying to think the number, it doesn't matter, it's about period poverty. If we could just hear a report from Councillor Slater, please. For the record, yes, it's agenda item 8.
Okay, thank you. It's not a very long report, but last year at Health Scrutiny, we focused on a couple of task and finish groups, and the period poverty group was one that I sat on with Councillor Taylor, Councillor Bennett and Councillor Duffield. And we worked with council staff, Alex and a couple of the other staff who have helped to write the report. And we started to send out surveys to schools, surveys to the food bank, and it was quite clear from the information that we had back that there is actually period poverty within Trafford. It was quite shocking that some of the schools actually charge students £1.50 per sanitary product, which we found, if you're in poverty, how are you going to find £1.50 to buy one sanitary product? So we've been talking to the Red Box project, and they are going to help and support us to set up the red boxes at schools, at other council buildings, hopefully in libraries, so we're actually out looking for a volunteer from the Red Box company at the minute. And once we have that person, we hope that we will be able to do a lot more. And the Dress Down Fridays in the council now, the staff are bringing in sanitary products so that we can share those with the food bank. But we would like to be able to have products available in libraries, lots of other council buildings, so that if people are using the toilet facilities and are in need of a sanitary protection, that they will be able to access those on council premises. And then we do want to try and have a big launch around that. And obviously it got a bit late last year, and then we ended up in Purda before we were able to look to do a launch. But we're still looking to do a launch and invite as many people from the community as we possibly can, and just generally ask people what they think we need to be able to do to make sure that our young girls and women who are finding it difficult to provide protection, what we can do. Because we did find that from some of the schools that girls were missing school, and it was if they were having a period, or mothers weren't able to have sanitary protection going into work, so they were calling in sick, things like that. So we need to be supporting people so that they can actually function in society.
Okay, thank you very much, Councillor Slayton. Yes, I really appreciate the report. I think it's a fantastic initiative. Can I just ask, before I open up the wider discussion to the committee, I heard about young girls who go to very male-dominated arenas such as football grounds, whether you have approached places like Manchester United, kind of other big corporations which, could provide it for us. Thank you.
Yeah, we somebody that works for Manchester United Development, actually, she has set up a charity, and she is working. She's going to try and work with us as well around some of that stuff. It was brilliant, the stuff that she does. They do, I think it was a few hundred packs every couple of weeks to the food.
Yeah, it's called
banks.
Every Month, isn't it?
Every month. That's right. I can't remember what it was called. So, and when they first started doing it, what they did was they started to put a sachet of chocolate in, hot chocolate for people. And the feedback to the group was, can you just put, if you're going to give us something as a treat, can it just be a chocolate bar? Because sometimes I can't afford to boil the kettle. So actually, you know, period poverty, it's about poverty about everything, you know, across the whole spectrum. So that's what every month does. And, and it is somebody who works at Manchester United Development. And as it grows, we do intend to ask for sponsorship as well.
She
I think
was very vocal about it,
the
wasn't
ladies
she?
football team wants to be involved as well. That's what I understood.
That's an absolutely brilliant initiative. I wholeheartedly support it. So, any questions from members of the committee? Councillor Taylor.
Sorry, no, it was just a point really. I think it's really, I know the launch got a bit waylaid and we were waiting to hear about funding, weren't we, and things like that. And obviously we haven't got a red box volunteer. But I think it's really important if we do try and go ahead with it, you know, to just really publicise it and highlight the nature of the issue and the initiatives that we're taking to try and eradicate period poverty in the borough, really, because we did highlight that it was a really quite a more significant problem than we actually realised. There's some other point I was going to make, and I can't actually remember. If it comes to me, I'll put my hand up, Chair.
You can keep thinking as I ask for Councillor Hartley, yes.
It's just a quick question about, I suppose it's just a stigma around period poverty. So, you know, I suppose it's like the stigma around free school meals, and, you know, as was. And I'm just thinking, so I know it says the Red Box initiative that the donations get distributed through via the school nursing team in the absence of a coordinator. So is there like a standard way where, you know, sanitary products can be given out, particularly at schools? I'm thinking I'd hate to think of like a girl at school having to go and ask the school office, or, you know, something like that, which would just, you know, be very stigmatizing, I suppose.
I think that the point you make about period stigma is a massive one, and I think that what we need to be educating our kids to say that actually, you know, this is what half the population have. It isn't anything bad, you know. This is our life, and I think that if we can stop some of that embarrassment for girls, I think that and women, I think that will be really helpful. So I think that is something that we can ask, if we can go back to the schools to support. Actually, you know, should we just be having them on a big table? Should it be distributed a bit easier than actually sort of like knocking on a door saying, can I have some products? So I think, yeah, we do need to be abolishing that stigma.
Councillor Taylor.
I think that was part of our mission as well, wasn't it, to try and just really debunk all the stuff that does go on around periods and normalise it, you know, so girls and women don't feel ashamed or embarrassed. It's a normal physiological function, and, you know, it's part of day-to-day life, really. I was just going to say, although we've not done the launch, on International Women's Day on the 8th of March, there was actually a really with support from officers from the council, we did a really successful stall at Limelight, actually, and it was really, and the great thing about it was obviously women who were there, but again, with Limelight being where it was such a diverse sector of the community, and women from all parts of the community, you know, just having that conversation and, you know, really appreciating what was on offer and being able to talk about it. So I thought that was a really sort of positive initiative. So I think if we were to launch it borough-wide, I think it'd be really well received. So I know that we did the work, and it's really important that we finish it off, isn't it, I think, yeah.
Any further questions from members? Councillor Haddad.
I'm just curious. I don't know how you would incorporate this, but I suppose it's anecdotally from my experience that you find a lot of young girls now going on the pill continuously to not have their period, and obviously that's a bad thing, because if young people start to use contraception early, they're more at risk of breast cancer and all the other things. And I just wondered, have you sort of started to consider that in the round, you know, and how you might?
Last year we were only tasked to look at period poverty, but that might be a task and finish group that you might want to consider for this year.
Yeah. I'm just thinking about our public health colleagues here. It might be something that they want to, I don't know.
And how much of it is for that reason.
Yeah.
Quite a tricky thing to find out, isn't it? It's something we have to, but I just see the increase. We could have a look at the literature, definitely, the evidence. I'm not saying it's
Yeah. that wasn't within the scope of the work that we did, but obviously that is an issue as well, isn't it? Yeah, absolutely. Thank you.
Any other questions? Okay, so we look forward to hearing more about it and hoping that the launch goes ahead. Would you be able to come back in March and let us know how that's gone?
Hopefully we might be able to have a launch in March. I think actually
Okay.
International Women's Day would be something that we
Brilliant.
could work to. So
Okay.
I think if we can sort of like resurrect Anne and Joanne as well, we might be able to get it sorted. Thank you.
Thank you very much. Thank you so much, Councillor Slater, for coming this evening, sitting through the entire evening's meeting. Thank you. Very nice to have you. So we just move on to our final piece of work for this evening. It's agenda item 9, and it's looking at the Health Scrutiny Work Programme for 2019-20. Members have had the document for a while, so hopefully you've been able to see what we would like to look at within our remaining meetings. Again, just for committee members' information, Councillor Taylor and myself met. We decided that we're going to focus on the important objectives of the council. One of those we've done tonight, which is mental health. The others are obesity and exercise, and one other one is cancer prevalence and screening. So we've basically selected a topic from each of those areas for the rest of our meetings, with our March meeting to be a review, as you've heard from this evening, of people coming back who presented to us and giving us updates, because obviously as a scrutiny committee we hope to kind of have an influence and shape policy and progress, and it's really, really nice to kind of close the loop in our final meeting of the municipal year back in March. So our March meeting is reserved for analysing and assessing the impact of our interventions, and the other meetings are just as detailed within the report. We have also selected 2 topics for task and finish, so unfortunately we can't really accept any more now, because we have to work within the limitations of our capacity, both as councillors and as officers. So we have selected, given the concerns of GP closures in the north, we're suggesting that we look at the early indicators for picking up practices that are failing. I think this is something that CCG are pleased that we're looking into, because obviously there have been issues in the north. I don't know if our CCG Chief Executive would like to say anything about that. You'd be happy to comment? Okay, not at the stage. Just say that you'd be happy to cooperate with that as a task and finish group. Yes, thank you very much for that. Thank you. And our second piece of work as a task and finish group was really following on from the problems we had with children's services, and the fact that we had a lot of issues arising from staff missing from work because of stress and mental health issues. So I suggested as a draft, as a kind of option, that our second piece of work should be looking at the council as a promoter of mentally healthy workplaces, and it was really to undertake an in-depth review of how the council discharges its responsibility. It actually has quite a large, widespread responsibility for promoting mental health within its own premises and for its own staff, also with any employers that it works with partners that it liaises with, and also with councillors. So it was really just to review how that is actually working. There was a policy that I think has now been updated, but it was quite out of date. It was 2016 that the council had developed. So at that point, it was a quite out of date policy. I think it has been updated since, but it was really just to review the performance of the council as a promoter of mentally healthy workplaces. So those are our 2 suggestions for task and finish pieces of work. I'm very happy to make changes if the committee are not happy, or if the committee are happy with those pieces of work. That's great. So are there any comments on the suggested work programme going forward? Any comments? I mean, we have kept it a little bit light, because obviously we have reports coming into us, we have urgent issues that might need consideration. So those topics are not to fill the entire meetings, but those are the things that we would like to have an opportunity to look at. Councillor Dr. Carr.
I guess the only thing that I would be concerned about was, since our last meeting was on the news yesterday about the immunisation rates in children having fallen even lower, and what we can do, and I'm sure this is a concern that our public health colleagues who are here will really share. obviously this is more recently just hit the headlines again, and we know that they've been a problem, but they really are at a really dangerously low level now. And I guess that's been an issue, since our meetings and since we laid out the programme, but it's just whether there would be any room to examine that. I mean, in some ways it might fit. It's not really in the same thing, but with cancer screening in terms of picking up, encouraging, it does sit in a way in a similar theme, although it is obviously largely aimed at children. But I just think that it probably isn't right for us not to at least consider how we can look at that.
I totally agree, but I think as a task and finish, it might be more appropriate for the Children's Scrutiny Committee. But having said that, I'd be very, very happy to ask for a report and a presentation on that, because as I've said, we've kept our programme light so we can ask for reviews and spotlights. Yes, so perhaps we could ask for that at our next meeting, which will share the agenda with the obesity project. Thank you. Councillor Hartley.
Just a quick query about the second task and finish group, which is about the council being a promoter of mentally healthy workplaces. The mental health of council employees is obviously important, but I just wonder, is that really within the terms of reference for us as the Health Scrutiny Committee, focusing on the provision that the council gives to its employees?
Absolutely, yes. And it's not just its employees, as I said, the council has an obligation to ensure and promote, I can't say ensure, but to promote mentally healthy workplaces with employers that it engages with, within schools, which it has responsibility for. And we all know that schools can be an incredibly stressful place. I mean, teachers often suffer from stress and anxiety. So it's not just within the Trafford Council building, it's, a wider remit. And in fact, we do have a mental health champion within the council that is a councillor. And I think that we also want to scrutinise their role, because I think the committee would like to know potentially what they're doing in their role as a mental health champion. So that was really why I included it. But if there's a feeling amongst committee members that that's not a topic they want to consider, then I'm very happy to change tack.
Just a comment really about the immunisations. I just heard on the news as I was coming in that Matt Hancock, the Health Minister, is actually putting out an urgent strategy to deal with the problem and to increase the uptake, because it's, as you've rightly said, it's such a dangerous level. But I think there are measures going in.
Thank you, Councillor Haddad. I think we'll still be interested to know what we're doing locally, so I'm very happy to have that as a yes. Thank you, Councillor Lloyd.
Yeah, I'd just like to say, I mean, I agree with Councillor Dr. Carr about the immunisation. I think the immunisation may be slightly different to some of the screening that you do, and I think it could be a cross-cutting one for both the children's, but ours as well. Because the Start Well board will be looking at that as well, I'm assuming. So it'd be good to look at it in the round, if you see what I mean. The more people that look at it, we may have some more input and perhaps change it. And it's all right having a strategy, whether it works or not, because a lot of parents have been put off, I think, by some of the negative publicity about immunisations. And having had a child who had measles, I tell you, I would definitely look at immunisations. So for me, it's important.
Okay, yes, I mean, obviously we said we're going to ask for officers to come and present to us, and we can have a really good chance to discuss it and review it and scrutinise. But perhaps it's more important than a task and finish, because that's going to take quite a few months. But perhaps we would ask for someone to come and see us in our next meeting in November. Okay. Could I just get a feeling from members if you are happy about the second task and finish group? If you feel, I mean, it was really chosen because of the issues we had with our children's services and the fact that we had a lot of staff off sick through mental health issues was one of the contributory factors to the service having the review that it did have. And I'm very happy to change it if you want to, but can I just get a feel for whether people think it's an important issue? It fits in with the council's objectives of looking at and improving mental health.
Can I just say, I think it's very apt. I think we can see that the levels of stress throughout the country at the moment is just getting higher and higher, and it definitely has an impact on the way that people feel and the way that they deliver services. So yes, I think it's a good idea.
Thank you very much, Councillor Akinola. Any other comments? Otherwise, I will just take it that everyone is happy. I mean, you can choose which task and finish group you wish to be involved with. We will be inviting other councillors to join us if they wish to, particularly other scrutiny committees. So feel free to let Fabiola know which committee, which scrutiny task and finish group, you would like to be involved with. And Fabiola, will you be able to send out some dates, get some meetings? Okay. So we'll draw up a protocol of what we're looking at, why we're looking at it, and get back to you. But please do let Fabiola know which task and finish group you would like to be involved with. Okay, so just looking at the remainder of our agenda, there's no exclusion resolutions, and so we have reached the end of the meeting. So it's a little bit later than I wanted. So thank you everybody for your attendance, your contributions, which are so valuable. Thank you to our public and our officers for lasting the course and your presentations, and really great to have a really good journey home. Thank you. So I must thank Fabiola as well for her fantastic support. Thank you.